frustration. So like, you know what, let's go out in the street and blow things up.
All right. Well, hey, I have 9 o'clock. So I think we'll go ahead and get started. All right. Well, listen, good morning. It is July 14th for those of you keeping track. We were just talking about all the 4th of July festivities that happened 10 days ago. It seems like a lifetime ago, but then yet it, you know, it doesn't. So time is moving very strangely in the days of COVID. So, but we're grateful that we're here today and able to gather and provide you with some information and share some information with each other concerning telemedicine. So thank you for attending this ECHO. It is a project of the Heartland Telehealth Resource Center and the Missouri Telehealth Network, and we're offering this ECHO for providers in Kansas, Missouri, and Oklahoma, and anyone else who wants to join as well, because I know we have some other states that have been joining us, and we welcome you. So we are addressing topics, and we have come up with kind of a schedule as we move forward, and so you can look forward to getting more information about that. Our next ECHO is not until the 28th. So we're gonna go the 2nd and the 4th Tuesdays now instead of every Tuesday. So we are able to plan a little bit more diligently for you, and definitely will take your suggestions on any topics, or if you would like to present something that you feel like you are an expert on, we would love for that too. I'm Janine Gracie, Project Director for the Heartland Telehealth Resource Center, and I have the honor to moderate these programs. But before we get started, I'd like for everyone on the ECHO to go ahead and rename your ECHO screen to show your first and your last name. So if you would right click on your picture or your name, you can rename your screen and make sure that we see your first and last name and your state abbreviation. That would be very helpful for us as well as we do the question and answer sessions so that we can answer those questions appropriately. So go ahead and do that. Right click on your picture and click rename. Now we will introduce the hub team members. So we'll start today with Eve-Lynn.
Great to see everybody. I'm Eve-Lynn Nelson. I'm a telepsychologist in Kansas and PI for the Heartland Telehealth Resource Center.
Excellent, thank you. And Rachel?
Good morning, everyone. It's wonderful to see you. My name is Rachel Mutro, and I am with the Missouri Telehealth Network, Show Me ECHO program, and the Heartland Telehealth Resource Center.
Thank you, Rachel. Robert?
Hi, I'm Robert Stiles with KU School of Medicine, Department of Pediatrics, as well as work with the Heartland Telehealth Resource Center.
Thank you, Robert. Tim?
Good morning. I'm Tim Davis, Telehealth Manager at Oklahoma State University Center for Health Sciences in Tulsa, and I'm also with HTRC for Oklahoma.
Thank you, Tim. Karen Edison.
Hi, everybody. Karen Edison, Senior Medical Director, Missouri Telehealth Network, and Show Me ECHO.
Great, thank you. And last but not least, Heather.
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS in Tulsa.
Excellent. So I think we have enough time very quickly if we could go ahead and introduce everyone on the, and I'll just call your name out and introduce yourself, your organization, and the state that you're from. So let's start with Lauren Lester.
Hi, I'm a 4th-year medical student at University of Missouri School of Medicine.
Thank you, Lauren. Joe.
Good morning, everybody. I'm Joe Kingsbury. I'm the Associate Director of Operations for Missouri Telehealth Network and Show Me ECHO.
Thank you, Joe. Lauren.
Hi, everyone. My name is Lauren Dom. I'm a telehealth coordinator here for the Missouri Telehealth Network.
Thanks, Lauren. Kim.
Hi, I'm Kim Lorenz. I'm the nurse practitioner and director of health services at Westminster College.
Thank you, Kim. Angie. Oh, you're on mute still. There you go.
Good morning. I am Angie Johnson. I am with GL Loan Associates and I'm the executive assistant. And I'm from Missouri.
Thank you, Angie. Jerry.
I'm Jerry Wellness, Executive and Medical Director for Northwest Missouri State University and Mosaic Life Care, which is based in St. Joe and Maryville, Missouri.
Excellent. Anne. Well, Anne, we couldn't hear you. I don't know, you were unmuted, but the microphone wasn't working. So we might be able to come back to you. Yeah, well, okay. How about Callie?
I'm Callie Dallinger. I'm the Division Nurse Residency Coordinator for the Mid-America Division of HCA Midwest or Mid-America. And I am a PRN nurse practitioner for the University on the Go clinics owned by Truman.
Excellent. How about Mila?
Hi, I'm Mila Cunningham, a retired physician interested in the keeping up with what's going on.
Very good. Glad you could join us. Yvette? Oh, you're muted.
I'm Yvette Turner. I'm the CMO at Katy Trail Community Health in Sedalia, Missouri.
Excellent. Thank you, Yvette. Cecilia?
Hi, I'm Cecilia Bengal and I'm listening in. Very nice to meet you all and thanks for having me today.
Thank you for joining us. Renee?
Hi, I'm Renee Patrick. I'm the director at Southeast Missouri State University Autism Center in Cape Girardeau, Missouri.
Excellent. Thank you, Renee. Rita?
I'm Rita Maldonado. I'm with the Health Resources and Services Administration with the Maternal and Child Health Bureau. Thank you for having me.
Great to have you, Rita. Thank you. Helen?
Yes, I'm Helen Nguyen. I am a retired physician and I volunteer at the Social Welfare Board.
Wonderful. Thank you so much, Helen. And Chandrika? Chandrika, are you there? You're unmuted. All right, we may be able to catch her later.
Janine, she said she's here, but she's been having some trouble with pop-ups.
I see that now. Okay, no worries. And now we have PK on the line. Would you like to introduce yourself?
Hi, yeah, I'm PK. I'm a pharmacy student with GLO, and I'm just listening in, trying to have a better understanding of what's going on with the telemedicine world.
Excellent. Well, we're glad you're here, PK. That's wonderful. All right. So just a few announcements. In Echo, we use first names. So get used to it. That's what we're going to do. We're going to call you by your first name when we talk. That just creates a more connected environment. If you'll notice, Joe Kingsbury's picture has Ask Joe Kingsbury. So if you open up the chat and you hit to everyone, and then you get this little down arrow, the third one down, I think, is Ask Joe Kingsbury. And so we would ask that if you have questions for our speaker didactic today, to go ahead and put that into the chat, and we will get to those after the speakers are finished. And then also you can always just, unmute your microphone and ask. That's no big deal. But if you want to go ahead and type in your question, that's where we're going to do that, is in the Ask Joe Kingsbury portion. If you do want to ask your question, unmute your microphone, raise your hand, unmute your microphone, and just introduce yourself again so that we are reminded who you are. All of this will be available on Box. The presentation will be on Box, and anything else, any other handouts. If you have trouble getting into Box, just let us know, Lauren, and I can help you through that if you are having a little bit of trouble. And then really the value of Echo is in the cases. So please volunteer to do a case study. If you have something that you would like to present and ask a question and really get some discussion going on anything about telemedicine, whether it's a platform, whether it is reimbursement, whether it is going back and looking at how to maybe do a gap analysis with your telemedicine program, go ahead, let's ask that question and get feedback from everybody that joins the Echo. That's really where Echo's rubber meets the road, if you will. And so we would love to have any of those case studies. All right, we're going to get to the didactic. So today we have Eve-Lynn Nelson and Robert Stiles presenting concerning trauma and telemedicine. Eve-Lynn is a research advisor and supervisor for health psychology students conducting clinical research, and also offers GRA positions at KUMC in the area of telemedicine. She's an experienced grant writer and is the PI of the Heartland Telehealth Resource Center. And Robert is also a member of the HTRC staff and has extensive experience in government at the state and local level, including serving as director of the Kansas Primary Care Office. So we welcome Robert and Eve-Lynn, and we're going to let you take control.
Super, thanks Janine. Give me just a second to pull up the screen. So we're excited to present today. Schools have certainly been a hot topic in the news, and then I know with my own kids, it's a challenging time with so much uncertainty with schools. Having to decide, are we doing on-site schools or virtual, or what that mix is going to look like. So when we're thinking about our school-based telehealth, we're trying to think, how is the telebehavioral health part that we've done over time, how does that fit with the many stressors that children, families, educators, school personnel, and overall communities are facing. So today we're going to talk about our history with school-based telebehavioral health, and then really focus in on Kansas disaster outreach funding that's new for our school-based health centers this upcoming year. It was a grant really focused on some of the natural disasters and challenges our rural school sites have faced. Of course, then more going to Plan B as we're seeing really a lot of the pandemic needs. So it was already stressed communities, and then on top of it, looking at the pandemic impact. So we'll be talking about how does telebehavioral health fit in with all that. So we'll touch upon an overview of our rural school-based telebehavioral health program. We began in 2015 in terms of serving really our poorest areas in Kansas, in Southeast and South Central Kansas. And then also talking a little bit about the impact of the pandemic that we've experienced, and then our planning for the next school year. This slide's a bit singing to the choir. It's just really a reminder of how we became interested in school-based telebehavioral health It really is focused on the elements that we look across telemedicine with increasing accessibility for children in schools, really meeting the child where they're at, looking at availability and many of the challenges children face with access and availability to a child behavioral specialist, and then also acceptability. Really finding that schools is a place where there's less stigma associated with being seen in the school setting, and really finding that it's often a good fit for families who are new to the behavioral health system, who may never have seen a psychiatrist, psychologist, or other mental health professional, and really who feel comfortable because they're in that trusted school environment with school nurses and other school personnel who have helped them in many other situations, and then are introducing them to telebehavioral health. This slide also, I think, really points to some of the transportation challenges we see, you know, in terms of driving out to Kansas, really challenges throughout the different seasons. I know earlier on we were doing more airplane outreach, and I know it just reminds me with one of our schools, we had a whole year's delay with our airplane outreach, which really telehealth helps address some of those barriers. So the Telehealth Rocks project is our overall school-based telebehavioral health program. Again, really came about to try to address some of the social determinants of health and challenges that our children living in poverty are facing, with almost 30% of the children and families we serve in areas of poverty. Just again, reminders of some of the health outcomes and challenges, really challenges across health indicators, behavioral health indicators, and education indicators. So the need is huge. We talk about a 20/20 rule in child telebehavioral health, where about 20% of children will have a diagnosed behavioral health concern by age 18, and only about 20% of those children receive any type of services, with a much smaller percent receiving specialty behavioral health. And then just the technology we've been using over time with schools is the professional version of Zoom, and really over multiple devices. This speaks to the provider shortages that we see. This happens to be for psychologists and other behavioral health counselors, but just seeing the real shortages that we have in the number of square miles that our providers are covering. I could put up a similar chart for psychiatrists, for social workers, for behavioral analysts. The whole range of behavioral health really sees gaps in our rural areas. So school-based telehealth is a new way to answer the call. It really is looking to that school nurse or other behavioral professional as the linchpin, linking the patient and the guardian, the education system, the specialty behavioral health, and primary care. It's really the idea that we're all on the same page and we're linking up systems of care for the best of the child. Instead of phone tag or trying to get just pieces of the puzzle, it's more we can bring all those puzzle pieces together and again, use that to best serve the child and family. So this is again, why we got into school-based telebehavioral health. It's a safe and convenient space with trusted personnel. It's linking the multi-systems of care. It has a positive school impact, so it's kind of a win-win for the school and the child, where the child's able to stay healthy and ready to learn in the school. It provides many families a point of entry into health and behavioral health systems, and it does allow greater understanding of cultural needs, including rural needs of the student, because it's again more the broader community picture of what is going on with the child. It's also a great opportunity for our trainees to participate in behavioral health services and get a feel for providing services rural. So it's exciting that some of our psychology, psychiatry, and other behavioral health trainees have later gone on to practice rural because of the telebehavioral health experience. It's great that the direct clinical services, which we'll talk about a little bit more, they open up access a little bit, and it's really great because it's access to evidence-based care and really having a strong impact. But there's still a bottleneck with only so many telebehavioral providers. So Telehealth Rocks tries to go from here to here by also offering capacity building approaches with telementoring and ECHO, just like we're on today. We'll see that the schools have embraced ECHO and utilizing that community of learning to connect with specialists and with one another. It's also paired with engagement and family support, and then also with prevention services. We'll see that as we get to the new disaster behavioral health grant. It really is focused more on universal and targeted services, as well as the ongoing direct clinical care. With all our services, we're really aiming to deliver the best possible care. You know, it's not half face-to-face care. It's really looking toward how can we approximate all the same elements as in-person care. And I would say, and sometimes it's above and beyond. There's some real advantages to telebehavioral health and having that whole team. We always look to individualized decisions about who's a fit for telebehavioral health, looking at the developmental considerations of the child, the parents' preferences, the resources at the child site, and then also the behavioral provider's comfort. They always have the say-so in terms of who is a fit to be seen over telehealth. Just to give you an idea of the range of school-based telebehavioral health services that we've advanced over time, we see about 400 encounters a year across telebehavioral health services. So that includes family and behavioral therapy, so parent training interaction therapy, PCIT, psychological strategies for behavioral concerns, trauma, and chronic conditions. So helping support students with asthma or students with diabetes and some of the management and coping with chronic conditions, as well as behavioral strategies for autism and comorbid concerns. It encompasses medication management and consultation. It includes parenting and prevention approaches. So the OASIS parenting approach, it really pairs online curriculum for the parent with direct coaching over the telebehavioral health system with children with aggressive and other real challenges in behavior. It includes assessment, including telehealth assessment for autism, as well as functional behavioral assessment. It includes feeding and weight issues, including feeding team and seeing some of the real little kiddos over telehealth and working on feeding difficulties, and then also interventions for pediatric obesity. And then finally, our toileting services. I really like to talk about that service. It was one that our school nurses really said, hey, we're seeing that these are the kids who are bullied in our school and are really struggling. So it's really pairing kind of that school nurse passion to really help children that they see struggling. And then we have good evidence-based treatments for toileting concerns. And so pairing that expertise and behavioral expertise, and then really seeing a good impact with some students even being able to stay in school rather than having to transition out of in-person school setting. what we've seen with the pandemic and telebehavioral health, it's had a variable impact on patients' symptoms and resources to engage in treatment. So as families have been stressed, it has impacted just the availability to participate in treatment. The school personnel have remained a continued resource, even as we've transitioned to home-based telebehavioral health. That school personnel is still joining the telebehavioral health sessions and helping support the children and families. There's a lot of interest in general parenting resources as families are supporting online learning and really trying to wear multiple hats with their own jobs, and then also, you know, with kids who may be across elementary, middle, and high school, really how do you balance that and changes in daily routine. Some barriers or challenges have come as we've transitioned to home-based with the students, really thinking through some of the safety concerns in the home environment, the patient lack of access or unfamiliarity with technology. Although really the children and families have adapted pretty quickly. They've used Skype or other technologies to connect with family. So it has been a pretty seamless transition. We have had challenges, some with connectivity, so those are ones that have had to be worked through. And then some of the facilitators or extra good things in being able to connect with the home, with this, again, with the continued school personnel environment. There's a real student pride sometimes in sharing their home and their environment and getting to meet their pets and their dogs and their cats and their gerbils, all that kind of thing. And it's really helped get a picture of how the students are in their lived environment. That really helps us therapists and behavioral professionals get a better picture of how to tailor interventions to help the student. And then the use of the home environment, it really has some good impact with being able to try some strategies that we wouldn't otherwise be able to try. So that's kind of the background that brings us to the new project. And Robert's going to take us through Kansas Disaster Outreach Project and share some of the exciting things into the next year.
Sure, thank you, Eve-Lynn. And I'll let you know when I'm ready to forward the slides. So basically the work of CanDo, and actually the work of Telehealth Rocks Schools, first came out of work that we were doing in community clinics, and then we moved into schools. And the CanDo project is really a expansion of the work that we have been doing with Telehealth Rocks Schools, which it came from an opportunity. When you look at the counties of Kansas, SAMHSA has disaster recovery grants that they award every year, and it's based on the previous year's disasters. So in 2019, 51 of Kansas' 105 counties qualified by having a flood, tornado, some major disaster declared. And the work of CanDo really expands on many things that we were already doing. A lot of what Eve-Lynn has talked about is really tier three of this pyramid, which is sort of the intensive interventions. But we'd already begun to do work on parent-child interaction therapy, care training, which is a modified or comes from a PCIT approach to working with individuals that work with students and other things. So when this opportunity became available, we really decided that we wanted to kind of reconfigure the program and expand the program and continue all the work that we're doing with Telehealth Rocks Schools, but be able to really sort of implement this model that moves from tier 1 universal interventions that are trainings like psychological first aid, which is related to disaster recovery in the wake of a disaster, moving into targeted interventions, which would be like parent-child interaction, would be like skills for psychological recovery and other trainings that would be for individuals that work specifically with children. And then of course the intensive interventions like the trauma-focused cognitive behavioral therapy. Next slide. So you can see online training in psychological first aid really focused on schools, but one of the other things that we're doing is we've been having conversations with communities. So, really understanding that it takes, and the entire community is involved and engaged with working with children. So whether that's foster care providers, mental health centers, community coalitions, ministerial alliances, just really businesses in the community that everybody has, an interest and a desire to kind of work with the kids in their community, and especially really alleviate trauma. And one of the things that I really push hard is that we do a lot of work to deal with trauma in kids' lives, but we need to do as much as we can to, not cause trauma, so work on those areas in our communities that are causing traumatic, causing trauma in our children that are, so that we, the best thing would be to not expose them to trauma at all, or as little as possible. So really, this is those type of work. Child-adult relationship enhancement, which is really looking at how to have positive reinforcement and work with children in a way that you through positive approaches, you get the behaviors and you help a child develop positively rather than perhaps some of the more negative approaches to dealing with children. So next slide. And kind of moving up to targeted interventions, Skills for Psychological Recovery is an example of that. And so that's really focused on, kind of dealing with trauma in kids' lives and kind of working specifically, especially in the event of a disaster. So like I mentioned, this grant came out of sort of previous disasters in Kansas, but the federal government, SAMHSA, sped up the timeline for awarding the grants because of the current traumatic event that we're all exposed to, the current pandemic, which is definitely a disaster. So we expected to receive the funding in June, or to receive an announcement, but we actually found out in April and had an April 30th start date. So we're really pleased that we were able to kind of begin to develop the program, know that we have the funding, and take the time as we work with local communities and work with local school districts that are dealing right now with the disaster and in their wake, and begin some of the work earlier than we expected. So next slide. And then finally, the intensive interventions via telehealth, which is a lot of what Eve-Lynn, working on first names, Eve-Lynn mentioned in her portion, continuing to work with psychiatry, psychology, developmental, pediatrics. We're very pleased to be able to offer that, behavior analysis, and then also working on workforce development, working with local partners. But one of the real benefits of having this program and having this grant at Katy School of Medicine is we have postdocs, we have fellows in psychiatry, we have current doctoral students in psychology. There's a wide variety of trainees that are already on campus, and anything we can do to help create a better rural workforce, but also, especially as we look at rural needs and maybe not being able to have providers and all the types of providers, and specifically all the types of specialty care that may be needed in a rural area, the idea of exposing trainees and students to telehealth and getting them comfortable with that and getting them experience in that is the real benefit of this program, because a lot of both our rural needs are going to have to be met through telehealth, and they're certainly going to often be better than asking someone to travel multiple times, multiple hours for some of these types of interventions and work. Things like parent-child interaction therapy, for example, takes 12 visits, right? And so if you were asking somebody to travel 5 hours, 12 weeks in a row, and then return home, you can see how that wouldn't be possible. So next slide, please. So we also have been involved with telementoring, or ECHOs. So have had a wide variety throughout the period of both Telehealth Rock Schools, and now as we move into Can-Do. So some of the ones that we've done through Telehealth Rocks, pediatric psychopharmacology, ADHD, back to school, healthy lifestyles. And one of the things that happened was during the outbreak, right, when schools shut down, we were actually in the middle of an echo related to called Function Fridays, related to behavioral health, severe behaviors or problem behaviors in the classroom, and really working with teams in different school districts to kind of focus on some of the more severe behaviors that they were having difficulty with, students that they were having lack of success with, and work throughout the semester on, kind of focusing on that kid and learning some techniques and seeing the results. And so we had to really modify that whole echo because all of a sudden school wasn't in session. And so we're really interested in whether school staff would be interested in continuing, which they were, and especially really interested in how do we deal with children with behavior issues in the home, and also some of the things that they were seeing now that children were in the home, like for the first of all, limited time through telehealth, through Zoom and other classroom types, distance types where behaviors were coming out there, as well as just how do you provide support to a kid that you may have very limited access to and only through telehealth and through televideo. And so, really interested in kind of working with that. And as we move into the fall, we will be having, first of all, a back to school webinar focused on behavioral health needs related to back to school, and then move into a semester-long ECHO series where we're hoping to have teams from different school districts that are kind of working and kind of working together on behavior, whether schools in school, out of school, through offsite, onsite, partially onsite. We all know it's kind of up in the air how the fall is going to look, and we know that there are a lot of behavioral needs and a lot of really approaches that hopefully we can be beneficial and provide sort of a space for groups to come together and learn from each other and work together as we kind of look at this new coming up school year and what it looks like. So next slide. So one of the other things that we've had a lot of interest in, it's been very interesting as we've talked with the school districts that are working with CANDO. And one of the things I should mention is we are focused on the same school districts as we were with Telehealth Rocks. So 10 school districts in Southeast Kansas and South Central Kansas. But what has been interesting is, yes, they're very interested in the echoes on behaviors and rolling out some of these services and universal interventions and everything else. But one of the biggest things we hear both in the healthcare field as well as in education is the importance of resilience and self-care. And school superintendents really jumping on board with the idea that not only do we need to provide assistance and help and welcome our assistance as we work with children and behaviors and telebehavioral aspects of care, but also behavioral with teachers and school staff. The idea of helping them deal with the uncertainty and the issues and the complexity and the stress and the trauma that they're exposed to through this whole environment that we're in. And so really excited. We piloted this resilience training with small medical practices in Western Kansas in the middle of providing an ECHO series or webinar series on a monthly basis related to that. And then we'll be rolling that out this fall in the school districts that we're working with because there's been a huge demand and excitement about being able to offer this and help with self-care for school staff as we continue to deal with this pandemic. Next slide. So, like I mentioned, it's an uncertain year. We don't even still know what school will look like this fall, and many school districts are still sorting that out. I talked to my sister yesterday, who's a teacher in the Boothill in Missouri, in Sykeston actually, and they're talking about having some teachers teach online only, and some teachers in the classroom, and maybe allowing parents to have a choice about how their child is in school. We're hearing about school districts where some kids will be on campus some days and not on others, and just a wide variety of approaches. So obviously community and family stressors, both for students as well as for school staff and in the community overall. And really the idea of, we're very fortunate, very interesting. We just got our data for the last 6 months of the report to the University of Iowa related to the Telehealth Rocks grant every 6 months. And so in the period between July and December, the end of December of 2019, we had, probably going to be slightly off, but in the low 50s for numbers of patients, and then about 170 visits. And in the last 6 months, we had sort of more students, 67 students, and actually had more visits. So even with the transition to home and telehealth and all that uncertainty and the fact that the children weren't now in school and accessible for visits, and also weren't in school to be identified for the need for visits, we actually saw growth in both patients and visits and a continuation of care just as robust as we had previous to that. So it really does show that there continues to be a need, and I think all of us that interact with children are now in the home and family stressors and traumas, as well as just the uncertainty that they face every day of not really knowing what the world's going to look like and how long it's going to be like this, sort of that we all face, are all really showing us the need for continuing these services and for expanding the work that we do. Next slide. So wanted to also bring up Telehealth Resource Centers, which we partner with University of Missouri for this ECHO series. And so if you see the dark green 3 states, that is served by the Heartland Health Resource Centers, but there are a network of telehealth resource centers funded by HRSA, by the Office of Rural Health Policy, throughout the country. So every state is covered. And we really serve as a resource related to telehealth, related to both technical aspects as well as potential models, and really are here to provide resources and support. And so hope that you'll reach out with any of the questions that you have. Also want to mention that there are 2 national telehealth resource centers, one related to policy, which is the Center for Connected Health Policy, as well as one that I would encourage anybody who's looking at different types of equipment to reach out to, which is TTAC. And so they have really excellent I always refer to them, and hope they don't hate this, sort of consumer reports for telehealth. They're nonpartisan, they don't have, they're not selling anything, and they try to do reviews of technology, as well as are always happy to answer your questions related to technology, to tell you if they've looked at any types of products that you're looking at, whether that's, systems or, heart monitors or any type of distance or sort of technology that would be used for the provision of telehealth services. Next slide. I think that's it, right? Well, I really appreciate, really excited to talk about, I'm very passionate about trauma. I feel fortunate that sort of had some people who really pushed me when I actually was CEO of the health center in Missouri and worked with school telehealth, and began to hear a lot of feedback and a lot of interest both at the community level in some partnerships with local health departments and other groups, as well as from school districts, saying that we really have to focus on trauma, and we really have to understand how to better deal with both the effects of trauma and to try to alleviate trauma in children's lives if we really want to see successful kids and successful communities. So I think we're ready for questions if anybody has any.
Great, thank you so much for that great presentation, and those projects are much needed, and I know that people really got a lot out of that, so thank you so much. All right, Joe, do we have questions in the chat box?
We have nothing in the queue right now, Janine.
Oh my goodness, look how well you covered the topic. No questions? There's got to be some questions. Anybody have a question they would like to ask by unmuting your microphone and introducing yourself?
Janine, this is Karen. I would just say it makes me think of our trauma-informed schools, ECHO, and Rachel and others on MTN. Like, what do you guys think it would help to start an ECHO on trauma-informed schools in Kansas and Oklahoma?
Karen, this is Rachel, and just so everybody knows, the Missouri Trauma-Informed Schools ECHO is designed to get schools to utilize the Missouri formalized Missouri plan to become what's known as trauma-informed. And so they go through a very detailed process to do that, and it takes a lot of effort and a long time to get that done, but the ECHO itself is very informative, and it teaches you a lot of the things. I think there are like 12 different points or 12 different markers that you have to meet to become trauma informed in Missouri, and that ECHO walks through a lot of those. And so if Kansas, Eve-Lynn, if Kansas has a formal state trauma informed program, we would be happy to help. I mean, you guys do it too, but we'd be happy to help in any way to take a look at getting that as an ECHO.
That sounds great, Rachel.
I was going to say, I'm really happy to hear that, because I know, the legislature passed, I was in Missouri, and the legislature passed the statute and says all schools have to be trauma-informed, and it was one of those situations, like, as someone in Kansas, I can say this, since nobody can yell at me in Missouri anymore. It was very interesting. They passed it, and the school districts were like, what do we do? And actually, a lot of the work I did in Missouri came out of that, because they had just passed the statute, and school districts were really questioning, okay, now what? And it was before, the state did kind of come up with a model. The School Board Association, I know, worked on that a lot, but began to work with Dr. Melissa Maris with the University of Missouri Department of Education, who's already working with some school districts. And that's really where a lot of my work in Missouri came from, and even the impetus for school districts being interested in having therapists in schools as well as this other trauma work. So it is wonderful that Missouri has sort of that requirement that schools be trauma informed. As usual, they were, the legislature said it before anybody really had the model or understood how to do it. So it's wonderful to see that there's, the development of that real trauma focus. And I think it's been one reason why you've seen school districts embrace school clinics, and especially the provision of behavioral health services in schools so dramatically in Missouri. And to be honest, it's one of the reasons why the state Medicaid program finally changed the rules and started allowing behavioral health services to be offered with schools as the site, an allowed site. Until only a couple of years ago now, schools, you could not build behavioral health in schools unless it was related to an IEP. So great progress in Missouri. I'd like to see that in the other states.
I think more and more people are becoming aware of ACE scores, adverse childhood events, and the impact that has on people's lives. And I think this effort needs to go back really far. I mean, this stuff starts in preschool with people's unconscious bias, too. Like you have a little 3-year-old of color and a little white boy, and they both knock over a chair, and the little white boy, it's like, bad boy, and the little boy of color gets suspended. You know what I mean? This stuff happens not because teachers are bad people, it's just because they have unconscious bias. And I think we need to start this way, way, way back. So we don't start compounding, this "you're bad" kind of message.
I'm always willing to tell people that I have a secret agenda, which is not so secret since I tell everybody. I always say that the point of these services in schools is that my real goal is that a kid that starts school that comes from the most disadvantaged background and has experienced the most markers that may indicate trauma, and a kid that has the best background, everything that they need to be successful, have exactly the same chance in life. And until we as a society are willing to embrace the fact that every child deserves the exact same chance in life, we're not really succeeding as a society. I really believe that. And that's where trauma-informed schools was where I began in my work in Missouri, and we ended up getting, luckily, some Office of Health Policy funding to really move into that idea of trauma-informed communities. And because when I talked to the health department, right, the issues that they were focusing on, drinking, all of the public health crises that we have, as well as socioeconomic issues, they really drive a child's success in life. And, we can do a broader partnership in the community. We can talk about bringing in business, because a community that's successful is a community that their kid, you have the workforce you need to be successful. You have children that are successful. The other thing is, the hard part of this is, we can see some effects initially, right? We can see kids who are more successful in school, who aren't out of the classroom. But the real success is when we don't repeat. And I know we don't want to talk about cycles of poverty and all of that, but until we see the child of the mother who had him at 16 not have a child who graduates high school, who has a career, that's the real point of all of this. It's really about changing our communities and making for healthy individuals as well as making healthy communities. I come from public health, and I really embraced trauma because I think it's a public health concept.
I would just add on, with ACEs and some of the trauma-informed, our teachers and educators and the whole school community, when you start talking about ACEs, you also see it's just a group of folks who also have experienced ACEs, and I think it resonates with them. Trying to think about kind of in learning how to help the students. It also has some benefit to looking at how to help, themselves, just like, all of us can benefit from that.
All right, Joe, I'm going to ask one more time if there's any other questions that have come through the chat.
There are none, Janine.
Okay, all right. Any other questions for our didactic? We might be able to follow Karen's advice and end at 10 till so that we don't experience a Zoom fatigue. All right. Well, thank you so much for that presentation and for the discussion afterwards. That was enlightening. And I just want to let you guys know that the next Telemedicine Echo will be 2 weeks from today. We'll be on the 28th. I believe we are working to find someone or maybe a couple of people or a panel to talk about billing and coding for all 3 states. So definitely check back with us and we'll get in touch with you as well with that, that decision. And we look forward to seeing you. So thank you so much for joining us and make it a great Tuesday. Thank you.